This will be a little bit different from the prior talk in that there's probably fewer randomized controlled trials compared to the other anxiety disorders. Recently, though, some have evaluated the significance of specific clusters, particularly in younger children. And what's generally been observed is that for the avoidance and numbing symptoms, that is the C criterion symptoms, kids are much less likely with decreasing age to endorse those symptoms and thus to fall short of meeting DSM-4 criteria for PTSD. So one of the questions that often comes up is, are these kids who fall short of true quote-unquote PTSD really impaired, or are they subsyndromal in terms of their impairment? This was addressed in one study about a decade ago. Again, I apologize for the red print, which really doesn't project that well. But in short, what these investigators looked at was a group of kids, including younger children, who met all symptom cluster requirements for diagnosis of PTSD, as well as those who only met 2 symptom cluster requirements and those that met 1 cluster criterion. Again, not surprising to any of us in the room, traumatized youth with subthreshold criteria do not differ in terms of impairment or distress from those meeting full criteria for PTSD. And also of importance, this impairment was not related to comorbid conditions. Of some relevance to this group in particular, I think it is important to talk about the effect of trauma outside of the diagnosis of PTSD. And these are data that actually come from a review at our institution of 1,434 hospitalized inpatients aged 3 to 17 years of age. And we carefully characterized in this group the presence or absence as reported at any time over the course of their hospitalization, reviewing each progress note, each evaluation, each consultation, etc., as to whether or not there was physical abuse, sexual abuse, or the combination of sexual and physical abuse. And what we found that, again, is probably of direct relevance to this group is that when we look at the traumatized samples, those with physical abuse, sexual abuse, or the combination, we see increasing rates of antipsychotic prescribing. Also, when we look at discharge, we see a significant effect in terms of antipsychotic polypharmacy, with it being more likely in the abused cohorts. We also see that there's an increase related to the number of psychotropics, and also potentially reflecting a marker of severity or disease burden. We see that there's a longer length of hospitalization. And you see that increasing from the no trauma group around 6.7 days to 9 days with the sexual and physical abuse combined group. So what actually happened was we had a number of people who had witnessed traumatic events. They had perhaps seen someone get shot. They had seen someone die. They'd been involved in a serious motor vehicle accident. In order to make things a little bit cleaner, we wanted the no trauma cohort to have absolutely no trauma. So we excluded those kids from the analysis so that we could look at the effects specifically for sexual abuse and physical abuse. All right. Let's now delve into the specific evidence for some of the psychopharm interventions in kids. And we'll first start with the SSRIs. As you all know, these are 2 of these are indicated for adults with post-traumatic stress disorder, sertraline and paroxetine. However, despite being used pretty commonly in kids with PTSD, there's not really a lot of evidence in support of that. And we'll go through some of the studies kind of detailing that. And we'll also talk a bit about how we can potentially in child psychiatry be hindered by extrapolating studies from the adult world. Probably not taking into consideration developmental differences with regard to kids. The first study is an open-label study of citalopram, 20 to 40 milligrams over 8 weeks in about 24 adolescents. And what was generally observed was that there were improvements in the clinician-administered PTSD scale score, as well as in CGI. Overall, it was well tolerated. And I'm not aware that they measured QTC intervals in this study. Certainly now we're aware of the risk of QTC prolongation with this agent. The rest of the studies of SSRIs in kids with PTSD have really focused on sertraline. The first of which was published by Judy Cohen a few years back now and looked at adjunctive sertraline in kids who were being treated with trauma-focused cognitive behavioral therapy, one of the evidence-based therapies for pediatric PTSD. And what was observed in this study, although as you can see the numbers are low, and this probably was accounted for by the black box having come out right around the time that she was beginning the study and her having some difficulties with recruitment. But what you see is that there was no difference between groups in terms of intrusive, avoidant, or hyperarousal symptoms, nor was there a difference in total CAPS-CA score. The CA is the child and adolescent version of the clinician-administered PTSD scale. The next study, a larger study, was completed and published a couple years ago by Adelaide Robb. And this study is neat for a couple reasons, one of which is that there was a large number of patients that were screened, and following screening, patients entered a 2-week period of time during which they would receive kind of a non-specific supportive psychotherapy. Anyone who had a decrease in symptom burden by more than 50% did not enter the randomization phase. So this was an attempt to try to decrease the placebo response rate in this group. And what we see is that 131 patients were randomized, 67 to sertraline and 62 to placebo, 47 and 51 completing, both groups respectively. Discontinuation rates relatively, well, somewhat higher in the folks treated with sertraline. And when we look at the primary outcome, which was the change in UCLA PTSD index score, what was observed was that there was no difference over the course of treatment between the sertraline-treated kids and those who received placebo. Overall, in looking at the secondary analyses, no significant benefits were observed with the exception of the CGI severity change score, which in the completers trended towards being statistically significant, and in the last observation carried forward analysis was statistically significant. Again, these are some of the secondary outcomes, and I'm not clear as to whether or not that may have been accounted for by some secondary improvement in depressive symptoms as well. Always something difficult to tease apart in these PTSD studies in kids. The next study of sertraline in kids is a nice secondary prevention study of this agent, and this looked at a group of kids who'd experienced fairly significant thermal burns. Mean area 36%. PTSD symptoms were assessed using the DISC. They also used the Children's PTSD Inventory, and they did look at concurrent depressive symptoms. Sertraline was flexibly dosed, beginning at 25 milligrams and increased to 150. So a little bit less than what we see in some of the other anxiety trials. For example, CAMS, wherein the dose went up to 200 milligrams with a mean dose around 150, despite a similar age. What was observed is that in looking at the PTSD score as patient reported, there was no significant difference over the course of treatment. And similarly, there was no significant difference in terms of PTSD symptoms as reported by the parents. So another negative trial here. And this led to a conclusion or statement, rather, in the ACAP practice parameters published just a couple years ago by Judy Cohen and colleagues that suggests that there's insufficient data to support the use of SSRIs alone for the treatment of childhood PTSD. So very different from what you see in the adult guidelines, wherein the SSRIs are considered among the first-line interventions. Next, let's turn our attention to adrenergic activities, sympathetic tone, norepinephrine. There's certainly abundant data in the adult population, including data from our group suggesting noradrenergic hyperactivity, elevated norepinephrine concentrations, elevated plasma norepinephrine concentrations as well in patients with chronic PTSD. There are several reports looking at either norepinephrine or surrogate markers of noradrenergic activity in kids with PTSD, probably the strongest of which came from Pani Parvanidou's group in Greece a few years ago now, showing that in a relatively otherwise healthy sample of kids who'd experienced a single traumatic event, a motor vehicle accident in most cases, that norepinephrine levels increase over the 6 months following the trauma in the kids who have PTSD, as shown by this black line, and remain in the normal range, although continue to increase somewhat in kids who do not have PTSD. Certainly, we're familiar with adrenergic pharmacology. We have 3 drugs, which we'll talk about, that work on the system. Guanfacine, of course, selective for alpha-2A. Clonidine, non-selective as an agonist for all of the alpha-2 receptors. And finally, prazosin, an alpha-1 antagonist, which is non-selective, central and peripherally acting, and which has been studied in 8 or 9 double-blind placebo-controlled trials in adults with PTSD. So first, looking at clonidine, in the adult literature, there's 1 double-blind placebo-controlled trial of patients with PTSD, all of whom had comorbid borderline personality disorder. And in this study, clonidine was superior to placebo. There are 2 open studies, open-label studies suggesting clonidine decreases anxiety, impulsivity, and hyperarousal symptoms in youth with PTSD. There's also a nice prospective trial in a younger group of kids, preschoolers in fact, starting very conservatively and I think reasonably at 0.05 milligrams daily, then increasing to BID to a maximum dose of 0.15 milligrams per day. In this study, there was good tolerability and the kids improved in terms of their PTSD-specific symptoms. Guanfacine, again, less potent than clonidine and somewhat more selective. Probably that may account for some of the differences that we see in terms of clonidine and guanfacine when we look at these PTSD trials. To date, there are 2 double-blind placebo-controlled trials in adults using guanfacine, which have not suggested any benefit for PTSD symptoms. There are case reports suggesting that guanfacine may specifically reduce nightmares in kids with PTSD. Next, we'll move into prazosin. Currently here, we're at the case report level of evidence. We have 4 or so case reports at this time suggesting benefit, although I would add as a qualifying statement that you notice that most of these primarily work on intrusive symptoms and specifically nightmares. And that's really been the case for the adult studies of prazosin as well. It tends to be pretty specific for these B symptoms of PTSD, the intrusive symptoms.